Welcome everybody. This is our fourth installment of updates as far as cancer research goes from ASCO. Today we have Chris Benton. Chris Benton joined us from MD Anderson. So he did his medical school down at Baylor in Houston, did residency training in Houston, and did his fellowship down at MD Anderson. He did a special research fellowship in leukemia at MD Anderson, and was on faculty for quite some time in the field of leukemia at MD Anderson. And we have been privileged to have Chris join our practice over the last year. He's really risen the level of leukemia care in the state of Colorado. And I'm going to go ahead and let you have it, Chris. Thanks.
Thanks a lot, Hossein. Thanks for the introduction. Again, my name is Chris Benton. I'm a blood cancer doctor. I specialize in all kinds of blood cancers, actually, but especially myeloid disorders and acute leukemias. I also tend to see a lot of aggressive lymphomas. I'm going to talk today about research updates from the American Society of Clinical Oncology, or ASCO 2020. The annual meeting was held about a month ago. And I'm going to just discuss a couple of abstracts from this that I think are relevant and that I think sort of may be applicable to the audience here. I was told that the audience was primarily patients. I figure there may be some physicians and some other folks out there as well. And so I'm going to kind of try and gear my talk towards patients mostly. The first thing, let's see if I can get my slides to move forward here. The first thing I want to go over is just what does it mean when we say blood cancers? And so blood cancers include leukemias, lymphomas, and myelomas, which are sometimes called plasma cell dyscrasias. And these are just different types of blood cells that can become clonal and proliferate and form cancer, basically. The way that I think about these disorders very simply is that they are composed of different diseases that can generally be divided into two varieties. The first variety is an acute variety, and what that means is that these are more challenging to treat. They tend to be more aggressive. And what I usually say is that acute disorders are those that we need to treat right now. Chronic disorders, on the other hand, are less challenging, but they can be challenging, and they can become challenging over time. They can even become acute disorders. And so each of these, there's acute leukemias and chronic leukemias. There's a kind of acute lymphomas and chronic lymphomas, and there's kind of an acute and chronic phase to myeloma as well. Examples of these are acute leukemia versus chronic leukemia, like acute myeloid leukemia versus chronic myeloid leukemia. An aggressive lymphoma, like a diffuse large B-cell lymphoma versus an indolent lymphoma. Multiple myeloma, which is a more aggressive form of myeloma that needs to be treated, versus smoldering myeloma, which, in many cases we never treat, we just watch. Some of the abstracts that I'm going to be talking about are those that specifically are geared towards the more acute disorders. Although there were some interesting abstracts in the chronic disorders too, and I'll probably just mention those. In general, there are very significant advances that are being made in non-chemotherapeutics, so non-chemotherapy drugs and therapeutics for blood cancers across the board. I would say that the most striking advances are currently occurring with one, targeted therapies, and secondly, immune-mediated therapies such as antibodies or immunotherapy or cell therapies. And so when I explain these differences to patients, I usually talk about things in this way. Chemotherapy is cytotoxic and genotoxic. That means that it basically just destroys dividing cells. If we were to equate this to something that we have in the military, maybe this is like a carpet bomb. And so that is the traditional therapy that we've used for cancer for years. Since 2000, probably really earlier, even earlier than that, but we've started to use a lot of targeted therapies. And these are small molecule inhibitors this is very much like a surgical strike, maybe like a GPS-guided missile. And then there's also these even newer immune-mediated therapies. And these I sort of, for the purposes of this talk, I'm classifying as antibody therapies. These are proteins that bind to specific targets. Immunotherapies, where we sort of harness the immune system against the cancer, and even cell therapy, where we use immune-based cells in order to target cancer. And the way that I think about this, in terms of maybe a military analogy, not a perfect analogy, but is that this is kind of like training the soldiers to carry out the surgical strike. So this is almost like a special forces kind of therapy. And both the targeted therapies and the immune-mediated therapies are really making significant advances in cancer right now, and especially across the board in blood cancers. With that, I'll get into some of the abstracts. So I'll mention 3 notable leukemia updates. These are all abstracts on acute myeloid leukemia. The first one was a phase 1b/2 study of a specific inhibitor that targets a protein called IDH1. That drug is called ivosidenib, given along with a BCL2 inhibitor called venetoclax, which was approved for AML in about 2018, about December of 2018, for AML. And these 2 drugs were given together with or without azacitidine, which is a drug that we've used in MDS and AML for some time, because, again, these targeted therapies are quite effective and are growing in their use, especially in AML. The other 2 abstracts I'm not going to discuss, but I'll just mention. The first one is a drug called enasidenib that was given along with azacitidine. And this was shown to be beneficial in improving complete remission and overall response versus azacitidine by itself in patients with mutant IDH2 AML. And again, this drug enasidenib is a targeted therapy that's specifically hones in on the IDH2 protein and is able to benefit patients with AML because of its very specific activity against IDH2. And then lastly is a drug that looked at a drug that was an antibody therapy, a study that looked at an antibody therapy. The antibody therapy is AMG 330. And this was preliminary results from a phase 1 first-in-human dose escalation study of AMG 330. This is an antibody that specifically targets a protein on the surface of AML cells, CD33. And this was presented by Farhad Ravandi. This was a very interesting study that had some interesting correlatives as well. We've been trying to target CD33. There's one approved drug that targets CD33, but this is a newer agent that's also showing some promise. So I'm going to go ahead and talk about this first abstract, where an IDH1 specific inhibitor was used along with a BCL2 specific inhibitor in IDH1 mutated leukemias and hematologic malignancies. And so these were the people that were involved in this study. IDH1 is a fascinating discovery in AML. The protein IDH1 is isocitrate dehydrogenase 1, and it is a protein that's been known about for a very long time. It's involved in the Krebs cycle, if you remember that from high school biology. And it turns out that this protein is mutated in AML. And this mutated protein kind of is a driver mutation, so it drives the growth of AML. And because of that, just in the recent past, in the past 5 to 10 years, really, we've been trying to target this particular protein in AML. This is even more important because it's mutated in maybe 10 or 12% of AML. And its close relative called IDH2 is also mutated in about 10 to 12% of AML. And so together it represents almost a quarter of acute myeloid leukemias that have this particular mutation in either IDH1 or IDH2. And so there are 2 inhibitors, one that targets IDH1 and one that targets IDH2. And so this particular study looked at this drug that targets IDH1 called ivosidenib. is the name of the drug. And it was given along with BCL2 because there's an increased dependency on BCL2 in AMLs that have this particular IDH1 mutation. So they were given together. And so this is the study design. I put this up just to show that no matter which cohort the patient was in, they received both venetoclax and ivosidenib. Some patients received azacitidine. Some patients received dual therapy with venetoclax and ivosidenib only. One of the reasons that I think this is significant is because this is dual oral therapy. So these are patients who are not getting any infusions whatsoever. They're only taking oral medications in order to treat their acute myeloid leukemia. This is the breakdown of the patients that were in the study, mostly AML, although it is notable that there were 4 patients with a sort of predecessor to AML, myelodysplastic syndrome. So it's sort of a spectrum disorder where MDS can transform into AML. And so some of these patients with MDS also have the IDH1 mutation were included in the study. The overall response rate was quite good. And so you can see the composite overall response for patients in sort of all cohorts was about 80%. And so that's quite significant, especially considering that this is a predominantly oral-only therapy that's being given to these patients. This is the survival outcomes. Again, this is a small number of patients and it's early, but to see that the median overall survival is not yet met is quite impressive, going on 24 months for a disease like acute myeloid leukemia, which is, as I mentioned up front, a challenging type of diagnosis to treat. One of the interesting things that can be done in our current age, where we have next generation sequencing, this allows us to look at the specific mutations that are driving a particular disorder. And so when we say AML, for instance, we're talking actually about a very heterogeneous collection of diseases that have multiple different mutations. What was noticed about this is that patients that tended not to respond had active signaling mutations. So they had mutations in another signaling pathway. And these signaling pathway mutations have been defined. And why this is so important is because we are also developing specific inhibitors of some of these activated proteins. So for instance, we now have FDA approved 3 different FLT3 inhibitors. And so the way our field is moving is towards a very personalized approach where patients with more than one specific targetable mutation might actually benefit from targeting both of those mutations. And so it is very possible that in addition to targeting IDH1, some of these patients with FLT3, that we could indeed also target the signaling pathway mutation and better improve the outcomes of those specific patients. So the conclusions from this abstract were that this approach with Ivo and Ven, or ivosidenib and venetoclax, is an effective molecularly targeted regimen for IDH1-mutated myeloid malignancies. It's well tolerated, and it's associated, as I mentioned, with a composite complete response of about 80%, which is good for AML. And something I didn't mention, but minimal residual disease is something that we can measure after we treat a patient to see if there's any detectable disease left over. And MRD negative CR was achieved in about half of patients, and those patients did exceedingly well with responses ongoing. And so there's going to be more studies to come, more treatments using this kind of an approach on their way. I'll mention a couple of other abstracts, specifically with regard to lymphoma. There were a couple of notable abstracts on the treatment of aggressive B-cell lymphoma as well as Richter's syndrome. This first abstract took a known chemotherapeutic regimen, which is dose-adjusted EPOCH-R, that's used in some aggressive B-cell lymphomas, and added to that venetoclax, the same drug that we just mentioned, which is a BCL2 inhibitor. This is showing promising results. It's early, it's a phase 1 study, but I think that you're going to see more of this kind of approach in the future. where we add a targeted therapy to chemotherapeutic regimens, which we've done in leukemia as well, and is definitely being done in lymphomas and myelomas as well. And then secondly, there was a phase 2 study of venetoclax that was again added to dose-adjusted EPOCH-R that was used for Richter syndrome. Richter syndrome is a transformation of a chronic type of leukemia, lymphoma, into a very aggressive type of, or acute type of leukemia lymphoma. And again, there's some promising results in that approach. And then lastly, with regard to myelomas, I'm going to mention 2 abstracts in the treatment of multiple myeloma. And the reason that I mention both of these is because multiple myeloma has a specific surface marker that has been proposed as a target that can be used to treat multiple myeloma. And that is B-cell maturation antigen, or BCMA. And this particular target is the target of the therapeutics in both of these approaches, both of these abstracts. The first one is Teclistamab, which is a humanized B-cell maturation antigen bispecific antibody that was used in relapsed or refractory multiple myeloma. So multiple myeloma patients who had been treated heavily prior to enrollment on this study. And the second one was a CAR T-cell therapy that also targeted BCMA. And these were also relapsed and refractory multiple myeloma patients. Both of these are showing significant results, and I'm going to talk specifically about the first study. So Teclistamab for multiple myeloma seeks to target an unmet need for patients with multiple myeloma. And what I'd point out about this is that patients who have multiply refractory multiple myeloma have a very unfavorable course. The median overall survival is less than 12 months. One of the reasons for this, we think, is that we sort of run out of treatments. Multiple myeloma has seen an explosion of therapies and combinations over the past years. And, it's gone from a kind of a disease that's there's hardly anything to treat it with. And now we have so much to treat it with that the survival goes on to 7 or 10 years. But for those patients who, ultimately fail these therapies, there's nothing there. And so that's what this treatment serves to mean. These are all patients who had been treated multiply with different therapies prior. So what is a bispecific antibody? What that means is that researchers have engineered an antibody or a protein. An antibody is sort of a protein that your own body makes. This is kind of in the news recently with COVID and convalescent serum that is, supposedly has antibody against COVID and against cells with COVID. And so this is these are proteins that your own body makes. I sometimes call them kind of the bullets of the immune system, but they're very specific bullets, and they can target very specific proteins on the surface of the cell. And in this case, this protein was engineered to target BCMA, but we went one step further with this, and we also added to this an antibody that targets CD3. And CD3 is a marker that's present on T cells, which are immune cells that can help to eradicate cancer. And so in essence, this combination of an antibody that targets BCMA along with an antibody that brings to it a T cell puts into juxtaposition a T cell and a myeloma cell, so that the T cell is able to see, recognize, and destroy this myeloma cell. So this is an immune-mediated therapy that sort of seeks to train the immune system onto the target. And so that's how this works. And there's a lot of therapies that are being developed, because this is quite mutable and versatile. These antibodies can be created to multiple different targets. And we're looking at some of these in AML as well. And so this was the study design. This was a sort of classic phase 1 study design with a dose escalation. The eligibility criteria included that the patient had to be relapsed or refractory or intolerant to established multiple myeloma therapies. Patients who were enrolled in this study had between 2 and up to 14 prior therapies for multiple myeloma. That really tells you how far we've come in multiple myeloma, that some of the patients had kind of double-digit number of therapies for their disease. The median number of prior lines of therapy, different sort of therapeutic options, was 6. So these were heavily pretreated patients. Also, a good 86% of the patients were completely refractory to the last line of therapy, really meaning that they were at the end of the line for their disease with regard to treatment options. This is the duration of treatment response. This is a nice way to look at the way that a study is proceeding, because this is preliminary data for the study. But just to kind of break this down, the green arrows mean that patients are still on therapy. And so every one of these are the patients here, and every one of these patients that are on the study are still on the therapy. And so it's 16 out of 21 patients have an ongoing response in this study. Some are quite early, but some have been on study for quite a long time. And the dark blue here is a complete remission. And so you can see there's quite a few patients who have had a complete remission after multiple prior therapies using this drug. And the light blue is a very good partial response. And so there's also quite a few light blues here. So this is really quite a striking turnaround for these patients who have had prior therapies. It looks like this BCMA is a very legitimate target for multiple myeloma. So the conclusions here: the safety profile is manageable across all doses. One of the things that we look at are inflammatory events like cytokine release syndrome. And these were generally very low grade and manageable, confined to first step up and full doses. And once patients got on this drug, they seemed to do well. Response rates were increased with higher doses of Teclistamab, suggesting that the sort of maximum tolerated dose and the effective dose that's going to be used for phase 2 studies, dose escalation and expansion phases of this study are ongoing. And so this is quite exciting stuff for the world of multiple myeloma. I have a few final thoughts. Those are the abstracts that I wanted to mention. The first thought is that therapy for AML has really changed dramatically from a chemotherapy like 7+3 kind of approach that was used for decades, even to the point of, in 2020, we're talking about using oral-only therapy, such as a dual oral therapy or ivosidenib plus venetoclax doublet, as an example, for IDH1-mutated patients. And this is really based on molecular characterization. And what this means is that, we gather all of this information about the molecular drivers of a particular patient's cancer, and we're reaching a point, even in acute leukemias, where we can specifically target those abnormalities to try and improve outcomes. The second final thought is that targeting BCMA in relapsed refractory multiple myeloma is demonstrating what appears to be very marked progress in prolonging survival, even in those patients that are heavily treated. And so that's exciting stuff as well. And then lastly, if I didn't drive home this point enough already, targeted therapies and immune-mediated therapies such as antibodies, immunotherapy, and cell therapy are really changing the way we approach cancer treatment in blood cancers in 2020. And so I think it's a kind of a fun time to be actively treating patients and to be serving patients in our community, so that these difficult and challenging to treat disorders can be better treated. That's me. That's my number. And that is where I was last week at Bear Lake up in Rocky Mountain National Park. And so I think I'm going to turn this back over, and I believe that we have time for some questions.
Hey, Chris, can you hear me?
I can hear you, yep.
Oh, finally got the audio and video to work. We had a lot of technical difficulties at the very beginning. Thanks for doing that, Chris. That was a very comprehensive overview of ASCO. There's a lot presented this year. I thought that the BCMA CD3 bispecific antibody data was very impressive, as you mentioned. I think
the biggest thing, and I wanted to pick your brain about this, was the low level of adverse events. I think one of the things that's hampered by specific antibodies in other diseases, much as with ALL, for example, is the cytokine release and all the adverse events that you see with them. What do you think was different with this compared to the other bispecific antibodies?
It's a good question. We use blinatumomab, which is a bispecific antibody in ALL, which targets CD19 and also has a CD3 specific antibody attached. We have some patients that have no side effects whatsoever.
Mm-hmm.
It is true that the CRS is something that is seen infrequently with the blinatumomab, but by and large, the side effects, even with that FDA-approved drug, are quite manageable. But it did appear as though the CRS, or what was thought to maybe be CRS, was low grade, grade 1 and grade 2. I mean, this is very minor. It's on a 4 scale of grade. And so, it's probably the specific target and the specific antibody, the way that the antibody was engineered. And it could just be the specificity of the antibody itself. And so, for instance, even though there's a CD19, CD3 bispecific antibody, there are a number of drug manufacturers that are working on more and improved CD19 specific antibodies, and it probably just has to do with the specificity of those antibodies, how specific they are, if they have any off-target effects, and kind of how strongly they draw the T cells into targeting the cancer.
And I think with Darzalex, for example, everyone's trying to combine Darzalex as early as possible. It'll be interesting to see how this plays out, because I would foresee it difficult to combine a bispecific, and I could be wrong here, bispecific, with an immunomodulator and Velcade and dexamethasone. Do you foresee this being a treatment on its own or in combination, or maybe a consolidation?
So I do actually see this as a treatment that could be used in combination. We do have some experience with combining antibodies, and this is actually quite promising. And I think one of the reasons for this is that, by and large, there are fewer side effects with the antibody therapies than we see with chemotherapy and sometimes even with immunotherapy, where we have a lot of sort of autoimmune immune-mediated effects. And combining antibodies in patients where there are kind of few or lower adverse event profiles, there can be some additive effects, but by and large, these are quite well tolerated. The other thing is that multiple myeloma, but really all cancers, as you well know, tend to benefit from kind of targeting from multiple different angles. And so I think it's always worthwhile to consider how we can combine these therapies in order to better, eradicate disease, especially in these sort of heavily treated cases. So I actually do see that this therapy could be used in combination, and that multiple antibody combinations, could be used. Now, exactly how these are combined and when they're combined, that's a completely different story, and it does take a very stepwise approach, careful and methodical approach in order to combine these things safely.
Chris, I think you have a question from Audrey, who has asked, how do any of these findings or studies apply to CLL and SLL? CLL seems to be a very rapid evolving field, and it seems like every day there's always something new. So I'd like to answer that question.
Sure. Yeah. So among the studies I presented, I only mentioned one study that is relevant to CLL. That's not to say that there weren't other abstracts at ASCO that were important for CLL. But at this time, I just presented the abstracts that were more related to the acute disorders. The abstract I mentioned on Richter's. So Richter's is a transformation of a chronic lymphocytic leukemia or small lymphocytic lymphoma into a more aggressive form of disease. And this is something that kind of shows up as a lymphoma oftentimes with rapidly growing lymph nodes. And in that study, what was used was a dose-adjusted EPOCH-R, and to that was added venetoclax. And this was Phil Thompson's study at MD Anderson, and it showed some really promising results. So Richter's transformation, if CLL sort of continues to advance and become or transform into an acute form of the disease, then that disease is called Richter's. And this is a challenging to treat type of leukemia lymphoma. And patients with the addition of venetoclax to the chemotherapy actually are doing quite well. There's, many patients still on study, still receiving this therapy. So that was the only study that I presented, but there were some other studies right now, and what was presented at ASCO was looking at some of the combinations of drugs that are being used in CLL. And I just didn't happen to review those, but there are some studies that were presented. Nothing that was at this time, huge groundbreaking that I thought was relevant to this discussion, but there were some studies there that looked at those combinations.
Yeah, it seems like a lot of people are trying to combine a lot of therapies in a venetoclax, ibrutinib with CLL, but it's really unclear, what to do with some of that data, partly because patients with CLL do so well, and there are just so many options. So it'll be interesting to see how that pipeline changes over the next 5 years, because just so many options.
So we always think of that as a good thing, that there's, so many options that we have, our challenge then becomes how do we combine these to, to improve long-term outcomes and even cure the disease. And that's kind of where we're at with CML and CLL. And of course, not all CLL is kind of straightforward to treat, but certainly we've made advances. And the same thing is becoming true, I think, of the more acute disorders. So myeloma is kind of becoming like that in some ways. And now even acute myeloid leukemia, we're seeing a more chronic type of an approach to these patients where we're giving, targeted therapies and antibody therapies to just keep the disease at its minimal.
Well, thanks, Chris, for doing this. I appreciate it. I know you're very busy, and I appreciate you putting this together. And hopefully we'll have another talk around December when ASH happens. I don't know if it'll be in person or not, but
thanks for having me. I really appreciate it. And we're really building our blood cancers program here and offering more and more clinical trials. So we're looking forward to participating in these kind of quite striking updates in therapy, and these are providing really measurable responses for patients. So
great. Well, thanks, Chris. I appreciate it, and appreciate everyone logging in to watch us. So take care, and good night.
Thanks again.